Welcome to the Colorado Newborn Hearing Screening Training Module. This module was created in 2026 in an effort to streamline Colorado's newborn hearing screening program. This project is a collaboration between Colorado Hands and Voices and the LEN program through JFK Partners, with funding from Colorado Early Hearing Detection and Intervention. A quality newborn hearing screening program helps identify babies that need to undergo additional testing so every baby has the opportunity to develop their language skills, limiting delays. Early Hearing Detection and Intervention, otherwise known as EDI, aims for a 136 benchmark. By 1 month of age, we aim to have had a quality hearing screening completed. By 3 months of age, children who do not pass this newborn hearing screening will be diagnosed with a hearing difference, if there is one. And by 6 months of age, having that child enrolled in early intervention, language development opportunities for the child and for the family, and parent support. These 136 benchmarks are instrumental in language development for children with a hearing difference. Without a quality hearing screening at birth, babies are missed or not identified during the newborn process, which will cause delays in speech and language and ultimately significantly impact the achievement in school even years later. During this training video, you may hear terms like hearing loss, hearing difference, pass, fail, or referred. Using accurate, up-to-date language with families is important, and terminology is always changing. You will hear a variety of different terms during the training so you are familiar. However, it is best to use scripts when talking with families with the most current up-to-date terminology so as not to confuse the family. We will cover this during the training. We want to thank Utah State University's National Center for Hearing Assessment and Management, otherwise known as NCHAM, for their newborn hearing training video, and refer anyone that would like a more comprehensive training or educational credits to visit their website for more information. We also want to thank you, the newborn hearing screeners, who serve as our first vital step in the EDI process. As a mom to a profoundly deaf child who is now thriving at the age of 10, the information we were given during those first few months are what allowed us to be where we are today. So from the bottom of my heart, thank you.
This is an introduction to the hearing mechanism. Our auditory system enables us to hear birds sing, people laugh, dogs bark, music play, babies cry, and kittens purr. This complex system begins developing around 6 weeks gestation, and its structure is mostly complete by birth. Sound waves enter the outer ear and travel through the ear canal to the eardrum. The eardrum vibrates from the incoming sound waves and sends these vibrations to 3 tiny bones in the middle ear. The bones in the middle ear send those sound vibrations onto the cochlea, a snail-shaped structure that is filled with fluid in the inner ear. The sound vibrations cause the fluid inside the cochlea to move, creating a wave that travels through the cochlea. In the cochlea, this movement triggers a rush of chemicals into cells, creating an electrical signal. The auditory nerve then carries this signal to the brain, which turns it into a sound that we recognize and understand. The ability of a young child to develop language requires that they have access to it. This access can be in the form of spoken language, for example, hearing people around you speak, as well as visual language. For example, seeing people around you using sign language. A lack of access to language leads to speech and language delays. It can also lead to cognitive delays, emotional impacts, and social challenges. Identifying hearing differences early is important to help ensure every baby has access to language in whichever modality works best for them and their family. Thank you for being a part of this process.
Now that you've learned about how we hear and how important it is to identify hearing loss early, let's talk about when to screen. Hearing screenings are non-invasive and they're really pretty quick. They usually only take a few minutes. The initial hearing screening should take place at least 12 hours after birth. It can be done sooner if necessary, but there may be a higher chance of a did not pass result due to birthing debris in the ear canal. Infants who do not pass the hearing screening, whether in one ear or in both ears, should be re-screened in both ears prior to discharge, ideally at least 12 hours after the initial screening. There should be no more than 2 total attempts for the screening. Both ears must pass in order for the baby to pass the hearing screen. If you're working with a family who has chosen to do a home birth, please provide them with information about hearing screening and strongly recommend that the infant has a screening completed. If your site isn't able to provide the newborn hearing screening, be sure to provide a list of resources where the screening can be obtained, or suggest that they connect with their primary care physician to ensure a hearing screening is performed.
Introduction to Screening, Otoacoustic Emissions and Auditory Brainstem Response. There are 2 methods used for hearing screening with infants, otoacoustic emissions, OAE, and auditory brainstem response, ABR. The method your site uses may depend on the number of babies born at your site each year, as well as the type of nursery, well baby or neonatal intensive care. Here, you'll be introduced to both OAE and ABR, how they are similar, how they differ, and what they look like. Otoacoustic emissions, OAEs, measure how the cochlea responds to sound. During this screening, a soft earphone is inserted into the baby's ear canal. It plays sounds and measures an echo response that occurs in ears with normal hearing sensitivity. While the unit your facility uses may differ from this one, it is likely very similar. Auditory brainstem response, ABR, measures how the auditory nerve and the brainstem, which carries sound from the ear to the brain, respond to sound. During this screening, the baby will hear sounds through a soft earphone and have electrodes painlessly placed on his or her head. The electrodes adhere and come off like stickers and should not cause discomfort. While the unit your facility uses may differ from this one, it is likely very similar. Should you have questions about the device used at your facility, check with your newborn hearing screening coordinator. They may have resources available with information about your specific device. The 2 types of screeners both reliably detect hearing concerns, but do so in slightly different ways. OAE screening requires a bit less time to set up and perform than screening in ABR. But ABR is important in particular to help identify hearing differences for babies at higher risk of hearing loss. More on this in a bit. Preparation. Before screening, make sure you are prepared. While not always possible, it is ideal to screen when the infant has been fed, changed, and is sleeping. Check your equipment to ensure it is charged and functioning properly. It is crucial that the baby is calm for the screening. This helps ensure a high-quality screen and reduces the possibility of getting incorrect results due to the baby's state of arousal. It will be efficient for you and the family if you perform the screening at a calm time. The baby may be in a bassinet or held by a parent or caregiver. Try to perform screenings in a quiet room. This can ensure there is nothing interfering with the measurements. We are looking for responses to quiet sounds, so it is crucial that the surroundings are also quiet. Some infants should not receive a hearing screening, but instead be referred for a diagnostic hearing test. This includes babies who are born with ear anatomy differences such as microtia and/or ear canal atresia. Talk to your newborn hearing screening coordinator on how to help families get connected for a diagnostic hearing test. Information about scheduling the diagnostic hearing test should be shared with the family before they leave the hospital. Ensure you have all the supplies you need before you go into a room to screen a baby. Also, be sure your equipment is clean. Wash your hands and ask permission to touch the baby. If the baby is sleeping in a bassinet or the arms of a family member, it is best not to move them. Explain the test to the parents before touching the baby. Some parents want an in-depth answer about how the test works. Be prepared with a short answer in layman's terms for how the tests work. How to use the OAE and ABR. The OAE screener you are using has the screening machine and the prober ear tip, which presents sound. The red tip corresponds to the right ear and the blue corresponds to the left. Some equipment, like this, uses the same probe for both ears. Choose a snug probe tip, place it on the probe, and then put it into the baby's ear. To insert the probe, gently pull the ear up and back and push the probe tip into the ear canal. Do not hold the probe in the ear while testing. This can cause interference. Select the protocol on the OAE screen and start measuring. Look for a pass or a fur response on the screen. Do not measure multiple times in the same ear at the same time. This can result in incorrect measurements. Screen the ear that is most easily accessible first. If the baby is nursing, switch sides when the mother is ready. If the baby is sleeping, change arms so the other ear is facing outwards. If the baby is awake, wait until the infant is comfortable and quiet. OAE screenings are most easily completed when the baby is asleep. The baby may flail their arms or move their head when the probe is placed. Have the parent gently hold the baby's hands on their chest until they calm down. The ABR screener you are using has two parts, the transducers and the electrodes. The transducers are what you put in or on the baby's ears to present a soft sound. The electrodes are what you stick to the baby's skin to measure the brainstem's response. The screening equipment is measuring how the auditory system responds to sounds that are played through the transducer. Correct setup for ABR screenings depends on the equipment, so review the user manual for the recommended setup. You should always clean the baby's skin, then place the electrodes in the recommended places, often on the head and neck. Choose a probe tip that fits snugly in the ear canal, place it on the transducers, and put them in the baby's ear. Depending on your equipment, you may use an ear cup that is placed over the infant's ears. If so, make sure it is completely covering the ear. The red transducer always corresponds to the right ear, and the blue corresponds to the left. If you are using ear cups, make sure the cup is placed so that the transducer is in front of the ear and not behind it. To insert the transducers, gently pull the ear up and back and push the probe tip into the ear canal. Once you are set up, select the protocol on the machine and start measuring. Pause if the baby becomes restless. Most units have a pause button. The screening should take only a few minutes.
Considerations for the NICU population. Infants in the NICU are at a higher risk for hearing loss, so additional things need to be considered. Due to higher risk of a specific hearing loss, which is not detectable using OAEs alone, ABR should always be used to screen hearing of babies in the NICU. If possible, prior to the screening, talk to the family caregivers about what you will be doing. Oftentimes, parents are not at the infant's bedside when they are in the NICU. It is important to communicate with the parents about what the screening means, why it's being completed, and to ensure there is a follow-up conversation explaining the results with the family. Talk to the NICU staff to determine when an appropriate time to screen will be. The NICU is busy, so making sure you can be there at a time where the baby is medically able to be screened will be best, which is typically not before the baby is at least 34 weeks gestational age.
Troubleshooting. Here are some examples of problems you may run into. If the baby is crying, wait. You can ask the parent to help soothe, feed their newborn, or hold and gently rock the baby. Or, if the baby seems to be getting more upset, it might be best to leave the room and return to attempt the screening a little while later. Be sure you're performing screenings in a quiet location. ABR screenings should be completed in a space away from other electrical machines as much as possible. You might be surprised by all of the sources of electrical noise that can interfere with ABR screening. Refrigerators, monitors, HVAC systems, breast pumps, and cell phone chargers can all significantly interfere with ABR measurements. Ensuring the baby is snugly wrapped will help to calm them so that you can complete the screening more easily. Swaddling takes practice, but it can have a big impact. You can ask help with swaddling from a nurse or from the baby's parents as you're setting up the screening. There are many online videos to teach people how to swaddle. Check to ensure there is no debris fully or partially blocking the probe/probe tip. A clogged probe tip can lead to inaccurate or false results. Replace the probe tip if you see debris in it. If you're having difficulty getting results, try a different size tip. Tips that are too small allow sound to leak out of the baby's ear canal, and tips that are too big may not be positioned correctly in the ear canal. You'll need to have a variety of sizes available because baby ear canal anatomy varies widely. Some babies even need a different size for each ear. If you're having difficulty getting responses, remove the electrodes, clean the skin, and place the electrodes again. Sometimes an alcohol swab is sufficient to clean the baby's skin, but you may find that you have better results if you gently clean the skin with gauze and a product such as NuPrep gel. Occasionally, if an electrode has been removed or fallen off of the skin so many times that it is no longer sticking, you may need to replace it with a new one. Electrodes can't be touching anything except the baby's skin, so holding them in place during the screenings will not work. Simple things like skin and debris can interfere with the electrode's ability to record ABR responses. Impedance, or resistance to the flow of energy, can be easily checked for each electrode with most ABR screening equipment. Reference the equipment manual for your specific ABR screening system for instructions for how to check electrode impedances and for the recommended impedance values that are optimal for screenings. While sometimes things do go wrong with equipment, it is important to not assume that the equipment isn't functioning correctly when a baby refers on their hearing screening. You may check a baby one time if they do not pass the first screening for a total of 2 tries. It's best to wait a bit to rescreen the baby just prior to discharge if you need to try a second time. Screening too many times can lead to inaccurate results where a baby born with a real hearing difference is not diagnosed in a timely manner. If a baby does not pass the first screening in just one ear, the recheck needs to be completed for both ears. If they pass the first attempt in only one ear and pass the rescreening attempt only in the other ear, they have not passed the screening. Sharing results with the family and caregiver.
When sharing the results of a screening, it is important that you use scripts provided by your team. These help ensure that there is consistency in the communication with parents and caregivers, as well as medical professionals. There are scripts available for you to use, available on the Colorado Hands and Voices website, created by Colorado EDI. When communicating with parents and caregivers, be sure to include why the screening is being completed and provide clear communication of the results of the screening as well as the next steps. Aim to talk directly with the family or caregiver to communicate the screening results. Simply leaving a card indicating the results at the baby's bedside can be confusing to parents who often are not familiar with the hearing screenings or their importance. While it might be in our nature to comfort parents by sharing reasons their baby may not have passed their newborn hearing screening, it is imperative to use scripts to ensure that parents understand the results and the importance of follow-up appointments. We do not want to minimize the importance of the screening, but instead want to ensure the child has the best chance for access to language. Sharing a reason for not passing may minimize the need for returning, and besides, we don't know why a baby may not have passed their hearing screening. The best way to support the family is to highlight the need to return for a follow-up visit and, if possible, to get the follow-up visit scheduled before discharge. The terminology you use when sharing results with parents and caregivers is important, as we'll hear from Kenzie, a local Colorado mom.
So his first time around, the nurses told us he didn't pass, but time and time again, they just reassured us that it's normal. A lot of kids don't pass. They said, a big majority of our babies don't pass the first time. It's not a test. It doesn't tell us why. It's just a screener. A lot of times, like, babies are born with a ton of fluid in their ears, like it's nothing. But come back in a week and we'll repeat the test. And so we came back again about a week later, and again, he did not pass. And I guess during that time, they had told us, like, it's nothing, it's nothing, it's nothing. The number of times that we were told it's probably nothing, you have nothing to worry about, countless. And so we were told that we should just follow up for a test just to tell us why he wasn't passing. So we followed up and scheduled an appointment with audiology at Children's Hospital. And in that time, I think it was maybe 2 weeks before we could get in. So he was about a month old by the time we got in for the actual hearing test at Children's. And throughout that time, we were kind of reassured and didn't worry because he was having that newborn startle reflex at loud sounds, even quiet sounds like crinkling paper next to his ears. He was hearing those things and responding to those things. So really, like, we were kind of reassured that, like, yep, like they said, it's nothing. I, in fact, told my husband, like, don't worry about coming and getting off work. I was on maternity leave, so I just went by myself to this hearing test. And then the results came in, that he would have permanent hearing loss in both ears. And I was shocked, overcome with emotion. I was just floored that anything could be wrong and happen. We have no family history of any sort of hearing loss other than old age. And really, I would say for myself, and I would say probably big portion of the population, you don't know about the spectrum of hearing loss. It's kind of like, well, my kid's not deaf, like they're hearing things, which is why I wasn't concerned before that point. And so we got that news and I was just shocked.
The next step after the newborn hearing screening is to refer to the Colorado Hands and Voices Roadmap or your program's printable next steps document so the family can read through it when they are home. If a rescreen is indicated, be sure to get that scheduled before the baby is discharged. Encourage families to write down their baby's results, or you can write them down for them, to make sure that they are returning for the follow-up screening and being referred to audiology when needed. Another important document to hand families at this time is the Colorado EHDI Newborn Hearing Screening Brochure. This brochure outlines the need for the newborn hearing screening with additional information such as progressive loss and late onset hearing loss.
Calibration. Calibration ensures that the screening equipment is in good working order so that results of screenings are accurate. After repetitive use, it is crucial to have equipment calibrated routinely, typically every year. This will give accurate results. Some equipment requires a technician to calibrate it in person, whereas other equipment uses a different process, such as replacing the audio cable and running a calibration module on the screening equipment software. Check with your screening supervisor or equipment manual about the correct calibration procedure for your specific equipment. It is important that you use the right accessories for your equipment. Things such as probe tips may fit various pieces of equipment differently. Be sure that your supplies are clearly labeled so you know what to use with your equipment. Using tips designed for use with a different piece of equipment can give poor results.
Cytomegalovirus, or CMV.
CMV, or cytomegalovirus, is a common virus in humans which can range from no symptoms at all to life-threatening. However, during pregnancy, if the virus passes to a developing fetus called congenital CMV or CCMV, it is known to cause a hearing loss. CCMV is the #1 cause of non-genetic hearing loss in children. It is important to know that if a baby does not pass their hearing screening in one or both ears, this may indicate a positive CCMV infection. Even if a baby passes their newborn hearing screening, many CCMV positive children will be identified with a hearing difference during their adolescent years. There are multiple indications that a congenital CMV infection has occurred in a newborn baby, including the following: low birth weight, less than the 10th percentile, small head circumference, less than the 10th percentile, physical examination signs such as an enlarged liver or spleen, or a skin rash like bruising or petechiae. There may also have been a history during the mother's pregnancy to suggest a CMV infection, such as illness, findings on a prenatal ultrasound, or rarely a mother who has had a positive test for CMV during her pregnancy. If any of these risk factors are present for a baby, then a CMV PCR test must be completed before 21 days of age to definitively confirm or rule out this diagnosis. In Colorado, all children who do not pass their hearing screening, along with the risk factors above, or do not have their newborn hearing screening results entered electronically by 10 days of age, will have their dried blood spot screening tested as a safety net. However, it is best practice to do targeted screenings with infants who match the above risk factors by using a urine or saliva sample. You will find multiple documents to help your program CMV testing. First, you will find a flowchart on how to test for CMV. Next, on why my baby is being tested. And finally, for those that do have a positive test result, a document on next steps for the family and connections to parent support. If CMV testing for newborns who do not pass the hearing screening is not routine at your hospital, it is important to ensure that the baby's healthcare provider is informed of the results so they can consider testing for CMV. If CMV testing for newborns who do not pass the hearing screening is routine in your hospital, you are well on your way to helping identify newborns and educating families on what to look out for. Hearing loss caused by CCMV may fluctuate or be progressive over the first few years of a child's life. This is why identification early is so crucial. Early hearing screenings, referrals, regular monitoring, and treatment plans can help ensure that the child has access to their full potential throughout their childhood.
Database and tracking. The state of Colorado tracks results of newborn hearing screens for all babies born in Colorado, as required by state law. Those who perform newborn hearing screenings are required to report results unless the family declines reporting. The purpose of this is to help make sure parents and guardians for all infants who do not receive or do not pass their newborn hearing screen receive follow-up. If families don't have screening and follow-up results reported to the state in a timely way, the family may be contacted by the state to encourage them to follow up. Resources for referrals and follow-up. Parents should be given the next steps both verbally and in written form. People only remember about 20% of medical information provided during high-stress situations. And let's be honest, having a baby, while often exciting and joyful, is a high-stress situation. There are many options for printouts for the family to take home so they can read over the information again. Newborn hearing screening programs may have their own resources that they can share with families. If your program would like to use established resources or would like to use the Colorado-specific resources, the Colorado Hands and Voices website has downloads available for you to use in English and in Spanish. These resources help to provide more information about the types of hearing tests that might be performed and also provide information about hearing and the Colorado Hands and Voices organization itself. Here are some more resources to learn about hearing screenings and speech and language development.
Thank you, Colorado Newborn Hearing Screeners, for giving me the best opportunity to reach my highest potential.
Thank you.
We want to give a big thank you to the Colorado Newborn Hearing Screening. It has allowed us to get early intervention for our son, who was diagnosed with hearing loss at birth. He's now 16 and thriving, so thank you.
Thank you.
Thank you.